with the title of it's a thyroid case, MTC case. That is 2 minutes.
15 minit.
15.
Berdiri dah habiskan jelas kau.
Lupa lagi.
InsyaAllah, insyaAllah.
In this discussion, we will have this afternoon.
We'll have three discussion. So this is one, another 2 more.
One more adrenal, one more parathyroid.
Assalamualaikum and very good afternoon to all of you. So I'm Sharita, first year fellow from Sabah, and this is my supervisor, Miss Siti. So I'm going to present a case. 16-year-old boy, not no medical illness. He presented to us with a complaint of 1 year history of painful neck swelling. Sorry, the marker is a bit out. So but he also had the hoarseness of voice for 4 months duration, but he denied any difficulty in swallowing. And then he got no hypo or hypothyroid symptoms. So on physical examination, we found there's a 2 times 2 hard nodules on the left anterior thyroid area. And then palpable cervical lymph nodes at level 3, 4, and the largest is 1.5 centimeter times 1.
Now, what is the differential diagnosis that we're looking at? Then you go around. Differential diagnosis, we did a boy. Thyroid swelling and then potentials include thyroid swelling in the lymph node, so potentials include measured thyroid cancers. Okay. Who's going to be this? MTC, which has to the lymph nodes. Okay, next. Other possibilities to be middleweight carcinomas as well. Follicular? Follicular does not affiliate the very unlikely. Other diagnosis that we can think of? Maybe other non-thyroidal diseases, like polycystic hypomas. It's not centrally located, but it's
Okay, this is a physical examination of this boy. So maybe any one of you want to describe?
Syndrome is the spine is like spine pollutions, and then the thumb, I'm not sure what this sign is. And then like men to okay, so on this man one and two. Hey, look at the eyes. Can you describe the eyes? The eyelid, what they will call that? Inverted, right? The eye is inverted. The lips is full and that's and the tongue is fissure at the how do you call that? Also, neuron. Then when you spread is both the upper lips or there's a lesion at the left so what is that? But there is maybe some mucosal lesion or maybe some neurofibromatosis. Spread out. Like mouth.
basically patient has a pectus excavatum as well. Maybe it's not so prominent here. And then a lot of mucosal neuroma and ectropion as well. So at this point of junction, so what else would you ask?
Family history. What are the things that you want to know? What investigation you want to do?
So in this session, I think we should think about men syndrome, women to be. So we like to ask
Yes, so we call
men to be regularly
that.
to orphans because of neuroma associated with neuropharyngosis as well.
One more,
You
Pheochromocytoma. How about men to A?
men to A is regularly low and Parathyroid.
Hypo?
So the representation younger age meant to be fixed and partially.
What investigation you have to take?
So of course, yeah, so we have to take the certain classical in CA rule out of the PO during the family history of MTC groups, particularly thyroid cancers. Thyroid itself, throughout the sound, focus on the sound and biopsy, depending on the level of calcium, whether there is.
Okay, so the patient has no symptoms to suggest pheochromocytoma, and about the family history as well. He's actually the only child. This photo is just like, but it's just idea to give you the idea that it's actually the extended family, and none of the family has the symptoms or any cancer in the family. So we proceed with a bedside ultrasound. So anyone want to describe this ultrasound?
Next, thanks.
Sound like the position of the right thyroid. It is not used and but it is almost away the surrounding thyroid tissue, but it's irregular. It's slightly hypo compared to the thyroid tissue, but it's irregular, it's taller and white with micro and macro constipation. So it's a suspicion which need to be proceed with ultrasound like that you can see.
What about this lesion? This is on the left.
I cannot identify where is the normal thyroid tissue here with all the quite extensive constipation over the side.
Did you say anteriorly? Anteriorly.
Oh, it's as extra thyroidal extension as well, which the thyroid capsule. Muscle. So this is involved bilateral types, not nearly both species.
You want to try to give a TRAT scoring for this?
It's fine.
So this is a lymph nodes ultrasound at the level 2 and 3.
The not also suspicious because it's cause of the tendon shapes. Bilateral, both the right and left is suspicious.
Okay, so basically we proceed with the ultrasound guided FNAC for this patient. So anyone want to comment on this FNAC result?
Okay, so what I see here, there is the nucleus. The nucleus is multi-pleomorphic and enlarged. Then you have granular chromatin, some large cells. So otherwise, I don't know if there are anterior lesions. So you have to go out PPC. No, it's pictures. Your clinical findings and then my clinical findings, then will be.
Sorry, I have to run a bit. So this is a blood investigations that we ordered for this patient. We didn't send for calcitonin because patient has no money to pay for it. But from this juncture, you can see that basically the CEA is raised. And then the other things is that actually urine metanephrine, non-metanephrine is normal, and IPTH also normal. Just that the other investigations looks non-significant. So we proceeded with a CT scan. Boleh play ya?
The cells. The type of cells.
No, they didn't do because of not enough cells block. But the pathologist said because of plasmacytoid cells, absence of colloid, and combined with the clinical features. So amorphous saja. They didn't mention about the amyloid. Dia tidak buat staining time. But they give a highly suspicious of medullary. Okay, anyone try?
On the CT scan of the neck or thorax, there is an heterogeneous thyroid nodule over especially on the left sides that have involved the cannot see it playing between the trachea as well as the esophagus. And there is the movement of the fat muscles on the left side. On the right side, there is an there's a calcification of the thyroid. So that's why I would see what we can just repeat again. The Western group, is not involved. I only see the retrospermal extension, there is retrospermal extension of the thyroid.
Okay, basically there's a large lobulated heterogeneous enhancing mass, almost occupied the left side of the hemithyroid. And then with the retrosternal extension 1.9 centimeter only, but the poor plane with the strap and paravertebral muscle as well. And then it's causing compression with the trachea with the narrowest is 0.5 centimeter. And the carotid is displaced laterally. So we proceeded with CT, abdominal thorax, and also adrenal because of the suspicious of the main 2B. So anyone want to see the CT? Laju, sorry.
Adrenal, it's the right adrenal, surgery vision. Which is a main should be. Still we have, Pheochromocytoma, however, this region is not functioning, very insufficient. Functioning, not functioning. This is a right adrenal region. The adrenal is both normal. The urine is show like
The investigation, is it?
yeah. Comment a bit. It's the ceiling springs, all the functions are all common. Urine, methane, and brain. Sorry, it's race. All the race. So is there any your okay. So why do you went to the medullary thyroid cancer with metastasis bilateral cervical lymph nodes with Pheochromocytoma biochemically. How you manage this patient? To operate or
First, we had the arrange for MTC.
okay.
We work with an endocrinologist, enterprise surgeon, anesthetic as well. And I guess because of medullary thyroid and it's a functioning field, the mainstay of treatment will be to operate. And then we plan for the
Well, we can
surgeon.
utilize the flow. Utilize the flow.
Prof nak tanya soalan.
And during the MTT, they will ask you, can you resect these tumor? What do you think? Can you resect them?
When you see this medullary thyroid with nodal metastasis, are you happy or not? With this statement, do you think it's complete? Now the calcitonin tak boleh baca. CA is high, right? So apa lagi you nak assess? Because I don't hear, because when there is a cervical metastasis, I would like to know in the mediastinum, because that's the other thing that I recommends. Is it big or not? Mediastinal nodes.
There is a 1.9 centimeter notes.
Eh? Right? Then decide nak operate ke tak.
So basically, there's a few issues we related to this case, MTC versus pheochromocytoma. Basically, we decided to operate on this patient. So, but because of the pheochromocytoma, we are contemplated a bit. So we have a bit MDT discussion, and because of the function is not really bad, based on the endocrine input, so we proceeded with total thyroidectomy bilateral MRND. But the preparations for the pheochromocytoma, such as pre-operative preparation for patient, we did it before the surgery itself. So basically, we not really achieve the R naught, of course, but we remove as much as possible. The tumor is encasing the carotid, so we shave off the tumor from the carotid gland. The nerve, recurrent laryngeal nerve on the left side, we are unable to identify because it's already invaded by the tumor. So we transect the tumor at that region. So this is the full HPE of the patient. So basically, this is medullary thyroid CA.
That's residual tumor. But the CA, do we check the CA?
We did repeat the CEA, it's just reduced by 20 from the 80 to 50.
Consequently, we got a problem now because we need to send private where patient have to pay. Yeah, so quite difficult to monitor patient in hospital. So, what then to do? What's your next plan? It's possible to come to you, so think you want to the sleep, because you got a track step, it wasn't done.
Yeah, we are planning for the PET scan, doing it soon.
The temporary,
So because the appearance of this patient is meant to be, so we didn't test for the genetic, but will you suggest for genetic mutation for the other family members, or what is your next move for the rest of the family members? First degree relative.
but I think we wanted to go through the family history of going through the family history of the. So that is the problem.
If this patient is actually, if we find this is a red mutation, so what will your plan for the next plan for the family? This is red mutation. If we able to send and it's called come back as a red mutation positive. Okay, never mind because of the interest of time. So basically, my question is, if this is it supposed to screen for the RET mutation because the patient phenotyping is really obviously meant to be. So basically, the first degree relative has to be screened for this RET mutation because the prophylactic thyroidectomy for the subsequent family members is very important to prevent all this medullary because the outcome for the early prophylactic thyroidectomy will save the patients in the future. I mean the offspring. Okay, thank you.
Thank you, Ms. Rita and Ms. Siti. We will now like to invite Mr. Rizal and Ms. Anita for the next case discussion.
Bos nak macam ni ke? Ni okey. Berarti begini ha.
Dia tekan apa je? Dia tekan mana je?
Tekan right je.
Ha?
Right.
Right. Assalamualaikum and very good afternoon to everyone. I'm trying to make this case discussion as quick as possible. I'm Rizal from Hospital Putrajaya with my supervisor, Miss Anita. So I have this 12-year-old male with no comorbidity, non-smoker. He presented with intermittent headache for 3 months and worsened 3 days prior to hospital visit. He also had a weight loss for 3 months, associated with night sweats for 3 weeks. Otherwise, he denied any palpitation, chest pain, neck swelling, any anxiety disorder, family history of similar presentations, or any history of malignancy running in the family. So, clinical examination shows discharge was full. Pupils both were reactive. However, the BP range is very high. Systole ranging between 158 to 202, diastole 130 to 151. It's very tachycardic, 155. Other parameters were normal. Further examination shows no mucocutaneous lesions, no thyroid swelling. Cardiorespiratory system was normal. Neurological, even cranial nerve also was normal. So at this point, what workup that you wanted to do?
Why you say it's pheochromocytoma? His presentation actually headache, severe headache, and night sweats. Night sweats. Yes. And during examination, BP was high. So basically, it's a young hypertension. So you have to work up with why patient has a high blood pressure. So because so basically all the biochemicals are all normal. No AKI, no hypokalemia, even inflammatory markers were all normal. He complained of chest sweat, night sweat. So chest X-ray shows normal lung parenchyma, no TB changes or anything like that. I'm sorry because it is a referral from the other hospital, so we don't have any imaging that has been done to the other hospital. So because it's complained of severe headaches, CT and brain was done plain and contrasted, which shows diffuse bilateral cerebellar edema with mass effect likely compression to the brainstem, with obstructive hydrocephalus and tonsillar herniation, but no significant enhancement in the brain parenchyma. So at this point, the diagnosis was acute cerebralitis with cerebellar tumor. So he was referred to neurosurgical team. Bifussion was inserted, and neurosurgeon said it could be obstructive hydrocephalus secondary to posterior fossa tumor. After the bifussion, the hydrocephalus was significantly reduced, but the brainstem compression and tonsillar herniation remained the same. So they proceeded with MRI brain. There was no evidence of tumor, but there was acute cerebralitis. So basically, no further neurosurgical intervention was done. He was managed by medical team. So because he's complained of night sweats, and he's young, so they started anti-TB with because of hydrocephalus from the CT scan, as well as to cover TB meningitis. They took the CSF TB cultures, but at this moment, this result was pending. However, after 1 week, they started anti-TB treatment. The LT became worse, so they stopped it. And then they did ultrasound hepatobiliary system to assess the liver functions. Only shows a hepatomegaly with abdominal limb adenopathy, the largest 3.1 at para-aortic and para-caval. So because it's young with hypertension, the medical team referred to endocrinologist there. And during ward admission, they noted persistent paroxysmal high BP with tachycardia. They have to start two antihypertensive. Echo just shows left ventricular hypertrophy with good ejection fraction and normal systolic function. So at this point of junction, what will be your differentials and what your next of action? After Hadis apa?
Anyone? So at this point of time, actually, patient is going to have a cerebellar tumor, but there is also abdominal cardiopathy, right?
Yes, correct.
So still we can't be really sure what is the most what is the thing that is causing all the symptoms. So at this point of time, I would like to see biochemically, I would like to order more specific towards endocrine,
Yeah.
like urine catecholamine or fractionated epinephrine 24 hours. And also I would like to order C3 adrenal.
Okay, okay. So because of so you wanted to do an endocrine workup, hormonal endocrine workup. Okay. Yes. Okay. So the result was aldosterone renin and aldosterone renin ratio was normal. 24-hour urine metaneptine was sent with good urine volume and urine creatinine. The urine metaneptine was normal. However, urine normetanephrine is very elevated, 44 times upper limit normal, and urine 3 methoxytyramine also elevated 2.73 higher than the upper limit normal. So what can you conclude from this biochemical hormonal workup? Sorry? Yes, it could be pheochromocytoma. Why metanephrine is normal and normetanephrine is high? What can you conclude from this result? So basically, this patient is normethanephrine dominant because the methanephrine was normal. So what you want to do next after you after you see these results? You
Right. So I think looking at the blood results and the patient as a whole, we really want to know a few things we know of. One, the patient has a pheochromocytoma.
okay? So what your next plan of action now?
Looking at bloods, it's actually normethanephrine.
Okay.
Usually normethanephrine is associated to extraadrenal
Okay.
parathyroid.
Yeah, correct.
And looking at this condition, most likely you might have some sort of pheochromocytoma.
Yeah. So basically, you want to locate where the tumor is.
You will need a functional.
Okay.
Basically, adrenal is also good.
Okay.
You can do a MIBG for the validation.
So the CT plane shows is not adenoma. So I have a CT contrasted. Can you comment on the CT? This one. What can you see on that?
Here we can see bilaterally suprarenal molested on the figure on the left side that's extending down.
Okay, any features, any specific features on the tumor itself that you can see?
I think, so you can just go back a bit. Looking both sides at the time, but it looks heterogeneous and it's also irregular from what I saw on my first cut. It's also progressing on the renal vessels.
Okay, between on the left and the right, what's the most striking feature that you can see?
The left side looks bigger than the right.
Okay.
And I think the right side seems like a bit of a poor planes.
Okay, you can see the hypoechoic within the tumor.
Yeah.
So it's, what do you think?
This could be a necrosis, a tumor necrosis.
Yeah, it could be a tumor necrosis or cystic changes inside.
Yeah.
Okay, so basically the CT adenoma shows multilobulated heterogeneous bilateral suprarenal mass, which is larger on the left, and possible the hypoechoic hypodensity is due to cystic changes or necrotic changes. Both main renal arteries and veins are patent, no encasement. The right tumor has had close proximity to the IVC anteriorly, and the left with the splenic vein anteriorly. Otherwise, with adjacent structures were clear flat plane. So, at this time, what is your next plan? Remember, this normethanephrine dominant.
We need to know the extensions of the disease, so we do a functional scan.
Okay, what the reason you want to do a functional scan?
Basically, we want to know our intention of treatment. This is still a curative or acceptable disease.
Okay, the functional scan that we did is a rotated scan. The reason being because this patient is young with hypertension and he got bilateral disease, bilateral tumor. So because it's not epinephrine predominant, you have to exclude paraganglioma. And because it's young and bilateral disease, there is a component of hereditary predisposition of tumor. So you wanted to rule out any other else tumor that cannot be detected by the anatomical CT. So this is a rotated scan. So basically, you can see the red color there. So this rotated scan is consistent with the CT tumor localization. The CT scans, similar finding with the anatomical CT scan, but there was multiple sub-centimeter para-aortic and aortocable and mesenteric lymph node, which didn't take the static radio tracer. So basically, this tumor is evidence of somatostatic receptor avid bilaterally, but no, the lymph node is not dotatic avid. So what you want to do next? You have the static scan, you have the CT scan. Siapa next? Kai?
think we plan for unity.
Okay, our magic word today, right?
So,
Okay.
basically what we plan to do is to come to a conclusion on how to preoperatively manage this patient, and intraoperatively we need to decide whether it doesn't look like it's amenable for any areas sparing surgery. This looks like both the areas are mostly involved. So counseling the patient is important because removal of bilateral area plans, the patient needs to be on lifelong therapy. So
Okay, so we did MDT for this patient. We did endocrine surgeons, endocrinologists, radiologists, and nuclear medicine. But because he's young and had bilateral disease, we also counsel for genetic counseling to the patient family as well as genetics testing. So the genetic testing came back as VHL positive for the patient, but negative to the parents and the family members. So now what is our next actions? Knowing that patient had VHL predisposition.
revision, because this is positive BHL, and both of the adrenal is involved, and only uptake is at the adrenal. Then we can discuss the role of bilateral adrenalectomy, and further after that the surveillance to be hereditary.
Okay, because the tumor is quite big and patient is so quite small girl, so we did an open bilateral adenotomy. So the right adrenal tumor is a multilobated tumor size about 6 by 4 centimeter, adhered to IVC and was a small iatrogenic perforation to the IVC tag posteriorly, which we sutured primarily. On the left, the size almost the same. No, but normal adrenal tissue was seen at the lateral limb only. So post-operatively, patient was closely monitored in ICU. Endocrinologist started IV hydrocortisone regularly. However, on post-operative day 1, he developed paroxysmal SVT. So we consulted the endocrinologist. They said most likely due to rebound tachycardia from the high dose beta blocker they gave pre-operatively, and it was resolved after given bisoprolol. He was tubated on post-operative day 2, remained stable without any hypertensive medication. And he was discharged home on day 14 after 2 weeks admission. So any specific medication that you want to prescribe before he goes home? Adi?
So he has no bands functioning, so I think needs the steroid in terms of prednisolone. So I need to discuss with the endocrinologist.
Okay, yes. So they started on patient requires long-term hormone replacement. So basically, oral steroid was given, but because his patient is 12 years old, the dose adjusted. We consulted the pediatric endocrinologist as well. So he went home with 2 oral steroid. So this is the HP. So HP can be as is confirmed Pheochromocytoma with positive chromogranin A and sinusapticin. And the pathology, our pathologist is very hardworking one. So she scored this tumor, pass score and gap score, which is both have a total score about 12. So do you want to comment what is a pass score or gap score?
We can't really determine from the histopathology whether it's malignant or
Pass stands for what? Okay, tak apa. So What's the difference between pass and gap? It's okay. So before this WHO, just you were correct. You cannot define benign and malignant pheochromocytoma by histological. So WHO and the Tumor Classification 4th edition, they had this concept. They said all PPGL has metastatic potential. So they're eliminating the previous category benign and malignant PPGL. So they approach patient with PPGL based on risk stratification. That's why you need this score, pass and gap score. So pass stands for pheochromocytoma of the adrenal scale score. This score is only applicable to pheochromocytoma only. And they have about 12 parameters. And the score is 4 and more, meaning that this the pheochromocytoma has increased metastatic potential. If less than 4, no metastatic potential. However, this pass score has been validated by experienced pathologists. So the downside of this pass score is it has no clinical prognostication. As compared to GAP score, which stands for grading of adrenal pheochromocytoma and PGL, this score can be used both for pheochromocytoma and paraganglioma. It has about 6 parameters and it has clinical prognostication value. So during follow-up, knowing the patient has VHL, Gillian, any particular follow-up for this patient?
So I think keep an eye on the possible disease. I think something with the kidney and the pancreatic.
Yes, because it's a VHL, it's a hereditary condition with multiple organ tumor predisposition, either benign or malignant. In retina or CNS, you can get hemangioblastoma or retinoblastoma, renal cell carcinoma, pheochromocytoma, pancreatic NETs, and in the middle ear, you can get endolymphatic sac tumor. So during follow-up, because a patient had removed all the pheochromocytoma, repeated 24-hour urine metanephrine was normal. BP also was normal without any hypertensions. Neurosurgical TCA, they said the patient was functioning, but they plan to do repeat MRI or CT later. And he was referred to ophthalmology clinic to assess the retina. So far, the retina, both of his retina was normal, only got myopia and astigmatism. ENT clinic pending still. They wanted to look for the inner ear for endolymphatic sac tumor. With that, I thank you.
Most importantly is the free organ variation and variation of the urine. Certain and you definitely need a multidisciplinarity routine. And together with your anesthesia, you have that. And of course, it can be a very stormy intraoperative monitoring, yeah, and post-operative by the
Okay, thank you.
Thank you, Mr. Rizal and Ms. Anita. So now we would go to our last case discussion for today by Mr. Koh and Mr. Hussein as the moderator. Miss Koh. Sorry.
Yeah. How do I move this? Using your audio.
Just press right.
Right.
Got any video lah, bos? Tak ada
Make
video lah.
simple, tak ada video.
10 minit tambah 5 lah kan?
Ada TV.
We try to keep it before 4:30 because nanti kereta nak pergi shopping gerak ke 4:30. So by 4:15 kena kumpul kat bawah.
Yes,
Should be able to have that.
Good afternoon, everyone. I'm Ko, first year BNE fellow from HNZ Kuala Terengganu, and my supervisor is Mr. Hussein. So this is a 45-year-old lady with no pre-existing medical illness. Actually, she presented with a 1-month history of postprandial vomiting, with positional symptoms of loss of weight and loss of appetite, but no other specific symptoms. So as per usual, a patient comes in with such small vomiting. We'll send, on examination, the vital signs were normal, except for examination, there's mild tenderness at the epigastric region, but examinations of the other systems were unremarkable. So as usual, we send the initial blood investigations. The full blood counts were normal. The renal profile normal, but what was noted to be markedly abnormal was the serum calcium that was sent as part of the routine investigations, noted that it was high, 4.5, and on repeated, it was still high. And since the albumin is 46, that is considered already to be the corrected calcium. The other electrolytes were normal.
So at the moment, so what do you think? Sebelum. So dia punya simptom tadi tu macam mana? Simptom dia, what are the symptom? Is it anything that towards anything ke? Pathology from the symptom that patient presented? I think isn't it? More on the very unspecific kan? So kalau you jumpa patient macam ni, usually you akan buat the normal blood test investigation lah. Which has been shown here. Sini kita tengok balik blood test yang betul. Okay, so here, what is so glaring here? Apa tadi? Okay.
Patient have hypercalcemia, so it's 4.5 is high. So this is the most glaring thing at the moment, but the phosphate is in the normal range.
How you classify hypercalcemia?
So it can be primary cause or secondary cause.
No, I mean, based on the values here.
Severe hypercalcemia, so it's more than 3.
So you may have mild, you may have moderate, and then you have threatening of crisis and hypercalcemia. All right. So what is the causes for hypercalcemia? I mean, in general. So kalau macam ni, probably you want to organize your answers by classify. How you classify the causes for the hypercalcemia?
We can classify into whether it's case dependent or case non-dependent. Case dependent would be primary, secondary, tertiary, and then case non-dependent would be because of elevated vitamin D or normal vitamin D. So for primary, then we'll check the first of all, we'll check the phosphate. I think this phosphate is normal, correct? No. Okay. Okay, sorry. So low. So next thing will be pH. Check the pH level. That it's high or low.
So if you are classify your hypercalcemia based on the PTH mediated or PTH non-mediated. Kalau PTH mediated, for example, you mentioned about the primary.
Secondary.
Okay, beside that, what else?
The other thing is
PTH mediated. Okay. So parathyroid mediated, familial hypocalcemia, one of the causes that you need to consider also. Right? So how you going to exclude ataupun diagnose familial hypocalcemia?
usually for FHH, we check the serum phosphate. It will be normal or low. pH usually high, and then we check the serum 24 hours urine calcium protein ratio, and then if the ratio is less than 1 to 100 or 0.01, then it's suggestive of FSH. More than that, can exclude the FSH.
So this is the algorithm for investigation of hypercalcemia. It's true enough, as mentioned, we look at the phosphate. So for this patient, the serum phosphate was low, 0.46. Next step will be to send the intact parathyroid hormone, in which for this patient is 104, which is obviously is high. So again, as correctly mentioned, we need to exclude one of it will be the familial uric hypercalcemia by sending the 24-hour urinary calcium creatinine clearance, which is high in this. And because one of the causes we are actually toxicosis, the TSH is normal. So based on all this, the diagnosis points to the primary hyperparathyroidism.
Okay, now you have the diagnosis. So what's next going to do? Next, apa lagi? Belakang. Second line. Follow up lines, validation. So, so usual imaging, what's the first ultrasound, and so what do you expect to see in ultrasound? The pictures of parathyroid gland on ultrasound. Wait, the location. So it's not from the thyroid, not thyroid usually. Okay. Is that that? Any other imaging that commonly you do? Because you need at least how you localize to say that you are confident that you know where the location of that primary hyperparathyroid. So you need at least two, you need. So one you do ultrasound, second BB. Okay, BB scan. Any other imaging that commonly you do? Because sometimes you may have negative localization. What is the common imaging that you really available in your hospital? Because that's something to the city, in this scan.
So for this patient, the ultrasound parathyroid shows that there's presence of actually bilateral thyroid nodule. They classify as TRATS2. Although our main aim is to look for the parathyroid, but from the ultrasound, there's no sonographic evidence of the parathyroid adenoma. So because of that, proceeded with the systemic scan. Scan was done, and there's no evidence of hyperfunctioning parathyroid tissue in the neck and mediastinum. Since both the ultrasound and systemic B were negative for the parathyroid, we proceeded with the CT parathyroid protocol. And from the CT, there's no demonstrable parathyroid adenoma, but they've seen bilateral small thyroid nodule, which is both in the right and left. In the right lobe measures less than 1 centimeter. And in the left thyroid lobe, it was bigger, about 0.7 times 0.8 centimeter. And at this point, since there was no presence of parathyroid adenoma in the usual location, we started to think that could this be an intrathyroidal parathyroid adenoma. However, it was hypodense on the arterial face, in which it was atypical, because usually if intrathyroidal parathyroid adenoma, it will usually be hyperdense. So in summary, all the three investigations that we had so far, the ultrasound, systemic B, and the CT, not pancreatic parathyroid, it was negative for parathyroid.
So now you have this scenario, you have the investigation imaging that available in hospital or negative. So what you want to do? Right? Any other imaging that you may offer to the patient? You mean the PET CT? Compare dengan study itu. Tapi kalau dah BB negatif, CT scan negatif, boleh combine. You are offering the same thing. Okay, any other imaging that probably can help you?
For this system, I'm not exposed to all this, but what I heard about is all for this system.
For this CT, for basically it's a CT model. I mean, the CT scan. What about MRI? Any other? What about the possible intrathyroid? Even though the CT shows they got a hypotense, whereas in parathyroid, CT usually hypertense because of the high vascularity of the gland and compared dengan thyroid. But it's still possible, and it's possible. Or is there anything that you think that you want to do? Isman, ada tak? Venous sampling. So venous sampling, how venous sampling will help you? With the whole life, okay, that's possible. So you are looking for the IPTH, right? Okay, possible. What about the kalau I kata the intrathyroid FNA, is it will help? Okay lah. Thanks.
So this is a list of imaging modalities that could be utilized, provided it's available in the center. And this immersive localization also has been mentioned before. So now,
Okay, now probably we have problem with localization. Tapi this patient basically sometimes kalau probably lepas ni dia bagi sambar the patient ni frequently admitted because of the very high calcium level, kan? So required lulusan intervention. So beside the high calcium level, what is indication for the surgery in the primary parathyroid? Okay, beside hypocalcemia, any other indication? Tadi dah kita tadi 4 point something, kan? Yeah. Okay, kalau maintenance, what do you expect? That's too high, like usually what the size of the parathyroid? It's a big unit. So difficult for you to say that kalau you are unable to localize, going to be the malignancy. Okay.
so these are the indication for surgery. Mention in the book, if those who have apart from the high, all symptomatic patients is warranted for surgery. In asymptomatic patient, we consider for those with osteoporosis, pathological fracture, and with reduced creatinine clearance. So for this patient, although we have yet to localize the lesion, unfortunately, she has multiple recurrent admission within a short time frame for hypercalcemia.
Okay, so because of we know that one of our last resort is basically we have to do exploration. Yeah. Okay, so that's the plan. The plan is to do bilateral exploration because of we fail to do pre-operative localization. But what happened if we cannot find the parathyroid gland? And on the previous CT and ultrasound, there is a intrathyroid nodules, bilateral, both lobes, left and right. So kalau you tak jumpa during your that session, are you going, what are you going to do to the thyroid? Any, before we tunjuk what is our findings, anticipate dulu macam mana? What do you think? Rizal, okay.
Me and process session.
Heavy and process session. Okay, heavy, so which one? Left or right? You got both. Both on you.
One yang hypotense.
But both are actually hypotense.
Which one yang tak workshop? Yang the one is not workshop.
Both pun
Ini kalau dia hypotense, dia tak wash out. Kalau dia hypotense, baru dia wash out. Jadi,
What about Bobby
itu dapat misalnya.
Chief for minor sampling, we did explore the possibility of this. We inquire with the interventional radiologists in IKN. They said that they are unable to do it. That's the information that we get. So, not sure whether it's, does anyone else here has any experience with it?
Dia ada, dia mungkin tak ada dalam tapi rasa nampak apa. Enucleation, okay, one of the possibilities, isn't it? Enucleation. Every time you do it, directly, and body enucleation is a good option also. Okay.
So we proceeded with Parathyroid exploration, but fortunately, intraoperatively, we managed to find the right superior parathyroid gland, which is actually enlarged, measuring 1.5 times 1.5 centimeter, which was removed. And we also find that on the contralateral side, the left inferior parathyroid is also enlarged 1 centimeter, and that was removed as well. We couldn't locate the left superior parathyroid gland. However, the right inferior parathyroid was normal looking, so we preserved that one. So in total, we removed 2 parathyroid glands. So of course, it would be good if we can have the facility to have this intraoperative PTH monitoring. But unfortunately, it was not available in our center. So the HPE came back, the right superior parathyroid gland, which was the enlarged one, it was consistent with the parathyroid adenoma. And the left inferior parathyroid gland, it was a parathyroid hyperplasia. So last slide. Yang right superior. Nampak the left superior. Yang nampak left superior. It's like posterior, sorry, posterior view of the thyroid gland. Posterior view. So yang right on the side, left. Okay. So yang pangkat tu yang remove, sorry. Posterior view. Sorry. So progress, yeah, the PTH actually 2 months post-op, it was reduced within normal range, and the latest calcium has already normalized.
Okay, thank you very much. So that marks the end of our session. There will be free transport from Scapes to GPO. The transport will leave at 4:30. So far, per trip, it can only accommodate 10 passengers, and it will be 1 hour apart. That means we'll leave first trip at 4:30, second trip at 5:30. First trip 4:30. Then next, the first trip balik at 6:30, second trip balik at 7:30. 6:30. Or we can adjust lah, first trip balik at 6 and second trip 7. Because there is a worry of jam, actually. That's why they put the traveling 1 hour back. I don't know. I don't know. No, what you want to? Oh yeah. Okay. So before we leave, there is something we would like to show. This is first lah.
Hello, hello.